Hi there, I'm Teri Hart, the host and creator of The Heart of It All. I'm glad you're here. Since June of 2016, Canadians have had access to the Medical Assistance in Dying program, or MAiD, as it is more commonly known. On today's show, one of Canada's first practitioners of MAiD, Dr. Jean Marmoreo. Welcome to The Heart of It All. I'm Teri Hart. This episode of the podcast is brought to you by Capital Direct. We cannot plan for everything in life. So when life surprises you and you're looking for options, check out the Capital Direct Flexi Line. A Flexi Line can help support you and your family in moments where they need you the most. And then you can pay it back when the time is right for you. To learn more, visit capitaldirect.ca. If you're Canadian or from other places in the world where assisted dying is legal, frankly, even if you're from somewhere that it isn't, you've probably thought about this option and probably had conversations about it with loved ones. This end of life care is incredibly personal, and we all deserve to understand exactly what it is and how we are eligible or not if we want to explore this option. In 2024, 16,499 people received MAiD in Canada. That's 5.1% of all deaths in the country. The average age of patients was 77.9 years old, and in 2023, cancer was the underlying condition in 64.1% of cases. Since MAiD was legalized almost 10 years ago, Dr. Jean Marmoreo has been at the forefront of this medical advancement. Dr. Marmoreo is a doctor, writer, athlete, and adventurer. A trained nurse who then pursued a career in medicine, Dr. Marmoreo believes in cradle to grave care. In 2023, she was inducted into the Order of Canada. In 2024, was awarded the Distinguished Alumni Award for the Sciences from McMaster University, and in 2025 was awarded an honorary doctorate from McMaster as well. Dr. Marmoreo, a very, very big welcome to the Heart of It All. I am just so incredibly honored to have you here. Let's start at the beginning of all this. What is MAiD?
MAiD is a federally mandated program for all Canadians to have access to this privilege. I actually call it a privilege. That at the end of life, and end of life is a very broad category, but if you meet criteria, Canadians across this land have the ability and the right to access an assisted death based on basically the Canadian Charter of Rights, which is also your charter right to have kind of control of your personal body, autonomy, and make decisions about how you live, and now, fortunately, how you die. And that's kind of the foundation of sort of how this whole program got started in Canada almost 10 years ago.
Yeah, coming up to the 10th anniversary.
Coming up to the 10th anniversary, and I would say we have matured. I would say that we have in fact have a model of how to kind of do this for people who have grievous and irremediable suffering, and that's a very large category in terms of determining when people decide that basically continuing to live on this earth is for them a matter of great suffering, and it is grievous, and it is irremediable. So we are not able to help them find a way that basically is compatible with their life goals and values and comfort level, and basically just functioning day to day in terms of sort of what they're contending with.
So you say the program has matured in those 10 years. What has changed about the program, and how do you think the public perception of MAiD in this country has changed?
Okay, let me do the last one first because there's not anybody I now assess who doesn't know somebody who's had MAID. There's not a family member I talk to who doesn't know somebody in their circle who's had MAID. So at least now we know it exists, and it exists in the public mind, in the public frame, which is really probably the best news of all is people know it's around, you know? In terms of how it's matured, we went from sort of supporting each other with this grassroots organization, which became CAMAP, and we did it because we wanted to support each other, and we wanted to kind of make sure that we all practice to the same standard, and the standard is really high. And that has matured so wonderfully in terms of this organization called CAMAP. So the standards of practice are now just kind of, I think, absolutely stellar. I mean, we are the world's model for what goes into kind of doing this work.
What is made not? Because I think that there are an equal number of misunderstandings about what it is not as well.
Absolutely. And it is not a dial a death program. You can't just decide that you've had it, or you're frustrated, or you're terribly angry, or you're terribly disabled at some point in time and say, I'm out of here. There are very strict criteria. This is basically under the Criminal Act of Canada in terms of taking someone's life. You must have eligibility criteria that are, in fact, very strict. Otherwise, you will be charged with homicide. So anybody who undertakes to provide an assisted death for another Canadian citizen must, by definition, have satisfied all of the eligibility criteria that are in place before anybody is found to be eligible. So establishing eligibility criteria is, in fact, a very large part of what all of the people in Canada doing assessments and provisions take very seriously. And in fact, the criteria, in fact, are very rigorous. So, for instance, you cannot say, I do not have social housing and I do not have means, and I am living in a remote part of Canada and I have no social network. And that gives me grievous and irremediable suffering that will not be remediated, and therefore I have the right to ask for help to die.
Is it, but I am just gonna I'm going to address one thing here before, because I don't want people to be listening to this and thinking we're not being responsible to all of those complications with the program, Dr. Marmoreo. So just to say that this is happening in Canada, where we have a healthcare system that from coast to coast to coast to coast has been under immense pressure and stress. How much is the MAiD program under even more of a microscope, considering how our universal healthcare system in this country is also under such stress?
Yeah, it's interesting because um, the more and I'm in the community. I'm a community physician, so I do community assessments and provision for the most part. So that means I deal very much more with an elder population with chronic illness states, and less with the cancer people, even though cancer diagnosis is still the number one reason for requesting an assisted death. But in my little bailiwick, I'm dealing much more with elders. I'm dealing much more with chronic illness states. I'm dealing much more with people who have great fragility and are at the end of their natural life. So I deal very much more with the over 75 population. And what interests me and what surprises me is just the level of good care that most of our seniors in this country have access to and, in fact, are receiving. But your program is around care and caregiving. And I think the greatest stress that I see very often in my elder population is that they are now without that social support of the caregivers. And I'm talking family caregivers. I'm talking because families are remote. They're not living in the community with their elder parents, or the parents are in retirement homes. So the isolation of age and frailty and illness becomes a huge factor in terms of how I look after these people. And you have to take everything into account. But one of the things that I always take into account, I'm always gratified to see, is the level of medical care they receive. I don't find that our elders, in fact, are lacking in healthcare services. In fact, I find that they've got a plethora of health care services, very often in little silos, like the cardiovascular silo, the renal silo, the neurological silo, um, and is blending all of that care together to kind of create the picture of Why is this 85-year-old now asking for an assisted death? Why now? Not last year. Why now? Not 2 years ago when they had a stroke. I mean, on and on you go. You have to kind of take into account always what is the total accumulation of all of the factors that contribute to why a person says to me, I am suffering and there is no remedy, and I want a dignified death on my own terms.
So you have somebody who comes to you and speaks all those words and expresses that to you. Then you have to do your analysis of whether that person is eligible or not, Dr. Marmoreo. What are the qualifications? What makes someone eligible for an assisted death in this country?
Yeah, but there are rigorous criteria. You must have a serious illness, disease, or disability right off the bat. You can't just say, I'm tired and I want out. You have to have an irreversible decline in your capabilities. You must, putting those factors together, have grievous and irremediable suffering that cannot be remediated in any way that is satisfactory to you, the person requesting an assisted death. And it must be voluntary and it must be without coercion. And coercion is a sense somebody is being pushed into this, or that this is in fact being kind of laid on them in a way that is in fact a negative. In and by negative I mean that if they had their own way around it, they would not be wanting to do it. So coercion is an interesting factor. If I sense any coercion, a person will be not eligible at all. So one of the greatest coercions, of course, is I have no money. If I have no money, that is a coercion of a kind that sort of says, does that make you eligible for me? Absolutely not. Not unless everything else is already in place. Because if you have no money, and you are then now looking at being housed in a long-term care facility, and we know that historically nobody wants to be there, nobody wants to go there. We know historically from COVID that the in the first 6 months, the majority of deaths from COVID were happening in long-term care homes. Not publicly funded long-term care homes, but in fact private long-term care homes. But it's cemented for Canadians, this notion that a long-term care home is anathema. I will not accept it. And that makes then a request for an assisted death a factor in that it will not be remediated in any way acceptable to a patient.
So somebody can't come to you and say, I'm now at a position in my life where I have to go to a long-term care home, and I don't wanna do that. I'm 85 years old, so I would like MAiD. That is a societal coercion.
Absolutely. So everything else in place, like all the other factors, you put them all together to get there. Why is a long-term care home or nursing home necessary? So if it's necessary because somebody cannot really function on their own without that kind of level of care 24/7, you must put the whole picture together before you say, yes, you have no money, therefore, you're eligible. It doesn't matter whether you're 45 or 85. If you say I have no money, and therefore I want MAiD, you won't get it. You know,
I wanna jump into a very, very difficult situation for a lot of people where I think there's a lot of confusion around this program, dementia and the complications around that. Is there a window for someone who is living with dementia to make this decision?
absolutely. I've done it since the beginning. I have always considered dementia is a life-ending illness, with a kind of a trajectory of sort of 5 to 8 years. So anybody who I have ever assessed and followed, that basically, as long as somebody with a diagnosis of dementia has capacity, and by capacity, we mean the ability to understand the concept and the request that they are asking for an assisted death, and the understanding that their request will result in their death. What they're asking for is the means to die, and that they understand that that will in fact happen. And they have to be able to reason that and basically be able to express that to me over time. So it must be enduring. So that means anybody who I am following, and I follow people still regularly with a diagnosis of from cognitive decline to early Alzheimer's to medium Alzheimer's to advanced Alzheimer's. And it's always been that you must know when you are requesting that you understand what you're asking for and that you understand that you will die as a result of it. So it is that famous 5 minutes to midnight, not 5 minutes after. If midnight is when suddenly you don't know what you're asking for and you don't know that I am there to provide you with that death. So I follow people very carefully, and I'm not moving laterally to their cognitive decline clinics, to the Alzheimer's clinics and the memory clinics. We actually almost work in conjunction. If they're being followed yearly and then suddenly being followed every 6 months, I step up a lot more in terms of saying, we need to be very careful here now because you could be in a position where we do not think you have capacity to understand what you're asking for. And the neurologist and I, in fact, don't work against each other, we work with each other. So in Quebec, of course, as of last year, you actually have an advance request.
Okay, that's what I was gonna ask. Can somebody say, "When I get to X point, I want MAiD?"
If you're in Quebec, you can, but not in the rest of Canada. So ordinarily legislation would harmonize right across Canada. Quebec has always done things in their own. They've always taken the lead a little bit. I mean, they did in terms of even MAiD at the beginning. They had it in place in 2015. We took till 2016, the rest of Canada. But as of last year, the Commission on the End of Life Care in Quebec actually passed legislation that permits an advanced request.
And is it universal what that stage is, or can you dictate what that stage is in your advanced request?
Yes, you must, in fact, dictate. You must dictate every single item on what constitutes and what constitutes a request. For instance, I do not know my family members, and this is not just like today, but this is like enduring. I do not. I require feeding. I am in diapers. I do not get out of bed. You can list every single criteria, and then very often they must be met. However, when that happens is like anybody's guess, because it may not happen for 2 years or 3 years. But when it does, it triggers an assessment. It does not necessarily trigger a death. It triggers an assessment. Do you meet the criteria?
Do you imagine that this same process will happen in the rest of Canada that is now happening in Quebec?
Well, I sure hope so because over 80% of Canadians want this.
Sorry, I just wanna be clear. You're saying that that is being reported by Canadians? In surveys, we find that out?
Oh, absolutely. Oh, yeah. I mean, in the same way that, 85% of Canadians support MAiD, in general. If you're over 65, I can absolutely tell you that people want to be able to control what happens to them when they have dementia or when they have Alzheimer's. Nobody wants to be in that bed as a kind of a shell of somebody who doesn't know anybody around.
Listen, we just did an entire month of content in January on Alzheimer's for Alzheimer's Awareness Month, and what we discovered there is so, incredible in terms of advancements of diagnosis and therefore advancements in new medical treatment to slow the progress of the disease, but the fact is, to your very well made point, the diagnosis of Alzheimer's or dementia, frontal temporal dementia or vascular dementia is a one-way ticket. It's just a question of time, correct?
That's correct. That is correct, especially for something like frontotemporal dementia. Alzheimer's is such a big umbrella. The number of deaths that related to Alzheimer's and dementia, in terms of the mortality statistics in Canada in 24, basically 20% of all deaths were related to sort of dementia and Alzheimer's.
Not made deaths, all deaths.
All all the deaths, yeah, all the deaths across Canada. This is not a surprise because you're old. And most people die when they're old, not when they're young. But if you look at the number of people who died over 85 years of age, 70% of them had Alzheimer's and dementia. So it's common.
I mean, that number we had Dr. Amina Jabbar on the show in January, and she spoke about, the fact is the decline as we get older is, the statistics are you have a 1 in 4 chance after the age of 70, you have a 1 in 3 chance after the age of 80, and you have the 1 in 2 chance after the age of 90 of experiencing dementia of some kind.
Yeah, absolutely.
Who are the folks seeking MAiD in this country?
Oh, I still think the vast majority are people with cancer diagnosis. 60 over 60, 63, 64% of all May deaths in this country were cancer related. And then you go to respiratory conditions, cardiovascular conditions, and neurological conditions. Those are the big 4, and then other.
Do you imagine that with this new, what they already have in Quebec, this end of life directive around dementia, do you imagine that that will impact those numbers?
Probably not. Probably not, and I'll tell you why. If you look at just 2024, because that's the latest annual report from the feds, eh? The number of MAiD deaths that were related to dementia and Alzheimer's was only 11% of all of the MAiD deaths. So we're looking at 16,000 plus deaths that were MAiD deaths in 2024, and that's about 5% of all the deaths in Canada, 5%, and it's not gonna change much beyond that. I think we've seen the great leveler now. I mean, when we started in 2016, I mean, the year by year growth rate was 30%, 30%, 30. I mean, people thought, my God, Canada's going to hell in a handbasket here. This is just an open pathway. There will be no population in Canada after, 10 years at 30% growth per year. So, and then suddenly, whoop, you know, it hit the plateau. And we're sort of sitting at 5%. So is everybody else who's basically been doing, assisted death forever. Like in the Netherlands, they're at around 5% now too, because the population is aging. We're all aging. And, people want to control how they exit, life. So I think we're kind of in that range. It's going to be about 5% of the mortality figures year over year now. If you look at dementia in 2024, 11% of the MAiD deaths, not 70% over, no, but 11. Now, if we get advanced requests and people have more control over the criteria that says, okay, I haven't got any memory and I'm not going to consent in the moment because that's the whole point. But you can, put me down. Please, and that's what one of my patients said. I said, "Why am I here today?" And he said, "You're here to put me down." And he knew exactly why I was at his doorstep. He had no memory for anything in the day before, the hour before, but he sure knew why I was there. So you just have to kind of know that even if we put it all in place, it is not straightforward. So the fact that you meet all those criteria does not trigger your death, it triggers an assessment. People still have to come in and basically assess what's going on and look at that document that you signed and notarized after you had your diagnosis and after you had your discussion of your prognosis with your physician. They still have to determine you are eligible. It's not going to be just a slam dunk.
Okay. So, that assessment. So let's take ourselves outside of the dementia or Alzheimer's category, and let's take ourselves inside just any person who comes to you. They meet the criteria. They know they meet the criteria. They come to you. What documentation do they need to have to make a request for MAiD?
They can actually make a verbal request for MAiD, but basically we want the written request. We want the witnessed written request.
I'm just going to be really clear about that. So you make a written request, and it needs to be witnessed. Who who can witness?
A friend actually, and as of the change in the legislation a year or 2 ago, a caregiver like somebody who's basically hired a caregiver to come in to provide service, a nurse, personal support worker. We actually changed that legislation so that they were able to actually witness the signed document. The important thing is that it must be signed and witnessed at the same time and the same day as the person requesting.
Who cannot witness it?
A family member who is going to benefit from the estate.
Okay, that's clear.
Very clear. If you're gonna reap any of the rewards of the estate, you are not gonna be eligible to sort of be a witness to this request. And the request says also that you're doing it voluntarily, that you're over 18, that you have health coverage in Canada, and that you are basically requesting assistance to die.
Is there a specific like, is there a MAiD kit? Like, does somebody, download this from the internet, or do they just write it up?
You can download it from the internet. In fact, if somebody is reaching out to me to say, I'm gonna need your help, I say, "Well, we need a request." You get on the ministry site. This is very specific to Ontario now because different provinces do it differently. You get on the ministry site and search MAiD.
Okay, so they have the form, they fill out the form. It is witnessed by somebody who does not benefit from their death.
Yeah.
Does a person need to decide where it is going to happen?
Well, that becomes part of my assessment, because they make the request, and that triggers the assessment. And the assessment now has 2 independent physicians who will do individual assessments of that patient's request.
Is it up to the patient to find those 2 doctors, or do you have a colleague that you work with? How does the finding of the 2 doctors happen?
It's very interesting. It's actually finding the first doctor that matters because and you can do it through your own family doctor, you can do it through Dying with Dignity, you can do it through your friend network, you can do it through the hospital clinics. All you gotta do is say the word "MAiD," and people are obliged to actually assist. So nobody can sort of wash their hands of this anymore and say, "I have nothing to do with this." If you don't want anything to do with it, you are still obliged as a health professional to actually make an effective referral, or pass them on to somebody who is actually gonna, in fact, help them. So once the request has come to me, I will do an assessment, and I will at that point also, if I know there is no one else in place, reach out to my colleagues in the community, or you reach out to somebody in the hospital, the clinic setting, if that's where you are, to trigger the second assessment. So every hospital across Ontario now has a team. Even if you are a faith-based institution, believe it or not, you have a team, because you are obliged to make an effective referral. And they make an effective referral very often to me, to people outside the institution because the institution has got constraints. But they do very fast at speed dialing to find somebody who basically come in and do an assessment.
So, what happens in the assessment? Is it an interview? Is it a physical? What happens in the assessment?
My personal inclination is to always do an in-person assessment because I wanna see how they live. I wanna see what supports are there. I wanna see how they're managing. I wanna see how they walk. I wanna see how they talk. I wanna see everything. But Zoom, of course, this lovely instrument of kind of like communication and connection, changed everything. It eased this burden enormously to be able to kind of do Zoom consultations and assessments. Because very often, you're on a pretty time constraint basis if somebody who's declining quickly. And that's again where you get into your sort of, stage 4 cancer diagnosis because they can change very quickly and suddenly. And you just really wanna have things in place for them. But in terms of me, because I do much more in the community with elderly people who have got much more chronic states, I really want to be there with them. I want to do an in-person assessment.
So, you make sure your assessment includes making sure that what they're saying to you is 100% accurate about their situation. What else are you looking for, Dr. Marmoreo?
Well, they must meet all the eligibility criteria.
Let's repeat those eligibility criteria again, because I don't think we can say it often enough.
This is very true. You must have a serious disease, illness, or disability. Okay. You must be in an advanced state of irreversible decline in capability. It must be causing you grievous and irremediable suffering that cannot be remediated or alleviated on in any way that is acceptable to that person making the request. And it must be voluntary. There must be no evidence of any coercion in the whole process.
So you do the assessment, they meet all the requirements, they qualify for MAiD. Are they then saying where they want this to happen?
Yeah, yeah, and again, very often, if there's some people who are in, care institutions, hospitals, or nursing homes that have faith-based, MAiD will not be permitted, and so you must either arrange an effective transfer of care out of that. Some people will, if they're in hospital, will go home, and other people will say, "I don't have a home to go to anymore because I've been, in this hospital now for 6, 7 months." So we're very blessed in Toronto because we have MAiD House. And MAiD House is a facility that basically people can actually choose to go to or be transferred out of hospital to go to.
I'm just gonna ask one more questions about, can you decide, like, is there a limit to how many people are there for the,
No, no, although, I mean, I usually say to stop with 76 trombones, um, but yeah, no, I've been at provisions where there has been no one, which is, sad. I mean, it is crushingly sad. And I have been at provisions when there have been, 55 people, and a raging party going on at the same time. I have been in gardens where clearly the party started in the morning and was gonna go on all day. I say to people, there's no playbook here in terms of what this occasion is going to look like or be, because it's totally in the hands of the people who are making the choice.
well, then you're gonna hate my next question if there's no playbook. But here's what I think has been missing from the discourse from my perspective. Take me through the day of what ending your life with MAiD looks like.
I would say, I'm going to now paint a picture of what this can look like. So, no matter which house I go into, when I come in, it's very clear that there has been a breakfast celebration. There is This is not home cooking, I can tell you. I never see home cooking for the breakfast. There's always something been brought in, muffins or croissant or, because people say, "Well, people are coming, we must have food." So, food becomes a big deal. And then family members will come, and family members can be intergenerational. Certainly, even the granddaughter with the baby may turn up, because people will make an effort to come. And people do, because they can plan this, they do bring in the relatives from across the country and out of country as well. So, and then once the breakfast is kind of looked after, the nurse, because I work very hard at making sure the nurse comes only in the morning of, because the nurse must put in the 2 IV lines. When we are providing, a death, my criteria is that it better be done well and not botched. So 2 IV lines because we use a lot of drug, and that drug is delivered intravenously.
So, the medical professionals who are there is a nurse and the doctor who is administering the drug.
Yeah, yeah.
The drug is administered intravenously
Mhm.
all the time.
Yeah, interestingly enough, in the stats from 2024, there were no oral, administrations of drugs for MAID. Now, there's always the option of self-administration with an oral solution, and, what would do 16,000 MAID deaths in 2024, none were oral, which is, to my way of thinking, sure way of making sure you do the job right and don't get botched. And sometimes the nurse will come and go. if the nurse is comfortable that the lines are really good, they don't stay because I turn up usually about an hour or so after that. So not very often when I come is the nurse still there.
So let's say my death is planned for 11 a.m.
Yeah.
So the nurse would arrive at 9 a.m.,
9 or 10. Yeah.
9 or 10. I would have my intravenous 2 intravenous lines in 1 in each arm. You would arrive at what time for a death at 11 a.m.?
Around 11.
Around 11. In you come, and from that point on, can people do whatever they want in terms of last rites, in terms of any religious ceremony, in terms of music, in terms of paint that picture of that decision. It's wide open?
Yeah, that's wide open. That's always done ahead. I when people sort of say, "Well, what do I expect and what should I do?" I say, "What how you do this and what you do is totally in your hands, and it should be a kind of a family thing." So the music, the food, the numbers, the order of ceremony, because some people get very formal. They have readings, they have music, but again, it's that they know when I have come at 11, I'm not coming to sort of join the official living wake. I'm there to do the job. Nobody wants to socialize with me. I can absolutely tell you that.
So you come at 11
Yeah.
and then you administer the drug. Do you have a what do are you carrying a bag?
Yeah. I usually carry my backpack because I'm on the subway. I'm in Toronto. I say I anywhere the TTC goes, I go because that was my idea of how you service the MAiD community in this city. If you can do it on the TTC, you can do it. If you think you can't, then you're not servicing the community very well. So yes, when I get there, I am there to do the job. So I come with my draw. I go into the kitchen. I get the tray out. I'm filling 8 needles. This is big. Okay. This is not like I come in and this is a tray of drugs. And the person must be consented. So I must sit with that person and go through the consent process to know that they, in fact, are indeed asking for me to end their life.
How long does the consent process take?
2 minutes.
That happens after you have prepared the 8 needles.
Yeah.
Prepare 8 needles, consent, administer the drugs.
Yep.
How long does the administration of the drugs take?
4 minutes.
How long until after the drugs have been administered until the person is pronounced dead?
I wait 5 full minutes. Hands off, 5 full minutes before I pronounce. And I tell the family that because 4 minutes is fast. 5 minutes is an eternity for a lot of people. And I'm very clear explaining to family exactly how this looks and what it looks like so that they are not staggered.
Explain that to us now, what you say to the families, what this looks like.
I say, I'm going to be giving a lot of drugs because they see the tray of drugs. I'm going to be giving all of these medications into this intravenous. It will take me a total of about 4 minutes to do this process. And at the end of that, I can absolutely tell you that your family member will not be breathing, will look very different from how they look now, because once they fall asleep, from the time they fall asleep until I know they are not breathing anymore is happens usually within that 4 minutes. Very, very common. And after that, I will sit and do nothing for 5 full minutes. And they need to know that because otherwise they say, "What are you doing? What are you doing?" Shouldn't we close her mouth? Shouldn't we close her eyes? Shouldn't we, you know, is she okay? Is she still, so they know that we will do nothing for 5 full minutes. And I think people have to be prepared for that because they're not expecting that.
What do you think people are expecting?
I don't think they know. I think that's the problem. We do not sit with death at all in this culture. I mean, I've sat with people who I know were actively dying, and it has always struck me that nobody in the family understands what's actually happening at that point. And that's because we have no familiarity with this. We have no familiarity with dying as a process.
Even though 100% of us are going to do it.
Oh, absolutely, absolutely. And the drama on TV is never this long, slow. There's a breath, and then there's nothing, and then there's another breath, and then there's nothing. So people are always kind of processing, is it done? Is it over? Are they dead? What now? What does this mean? What has happened here? So we have no comfort with this at all.
So you do everything you can to prepare people for that 5-minute wait and then the pronouncement of death. And then what happens after the death, especially for those who choose to do this in their home?
Yes. Well, and again, I think there's a little ritual in here. I mean, and it's interesting because a lot of practitioners in the early days ritualized the giving of the drugs even, and they ritualized that the end of it. I mean, one of the Quebec doctors I remember very well talking about how he gave little candles out to all the family members who were at the provision so that they would know, in a day or in a week, they would light the candle and remember they ritualized the process for the family. So I have a ritual, and when I do the pronouncement and I say time of death. I don't say time of passing, I say death. They need to hear death. And now that we don't actually have to call the coroner's office, my other part of the ritual is to take out the IV lines for the family. And I do this because I just think there is a process of caring for a dead body that again family members are not familiar with. And you just what do we do? I mean, oh my god, what do we do now? They know they're going to call the funeral home and they know that somebody is going to come to take away mom, but that process of, well, what do we do? And especially if somebody has chosen to actually have that procedure done sitting on the couch with the whole family surrounding them. What are you going to do now? So I actually ritualize also taking out the IV lines and placing the body in a more comfortable position, and taking glasses off, for instance, and just basically, placing hands across the body, chest. I mean, it's just so that people know you can handle a dead person with care and with love.
When you say in a more comfortable position, does the body change positions when
Well, very often, yeah, very often I will close eyes, and very often because the jaw is very slack. If they've been sitting up and their head drops back and their mouth falls open, you want to make them more comfortable. So you want to prop the head up much more, and you want to bring the head forward, and you want to kind of close the mouth if possible.
you have performed hundreds of provisions in your profession, in your professional life, is there any universal truth from those who are about to have a MAiD death or for their family members, for those who are present? Is there anything that you've experienced, Dr. Memorial, that is universal for people?
I guess the biggest universal sense, emotion that I just see absolutely over and over and over again, especially in my population of elders, is peace and just grace. I mean, there's no fear. There may be a lot of apprehension and anxiety in the family members, but I can absolutely tell you that in my elder population, what I see when I walk in is just that really calm resolution and peace, truly.
Wow. Um, you said we don't have to call the coroner anymore, so you call the funeral home
The
to
family members call the funeral home, And again, they understand this ahead of time. So you don't want to suddenly find people saying, "And what happens now? What do we do now?" So I'm very clear with family members who is going to call the funeral home. When are you going to call the funeral home? What kind of timeline? Don't get rushed. Don't be uncomfortable. They don't have to come, like, within an hour. Yes, you could certainly, keep your mom with you for sort of 6 hours if that's what you want, and then call. So and I usually ask family members to just give the funeral home a heads up that there is likely to be a death, that somebody is in decline, just so that they can hear from the funeral home, "Don't worry about it. We are here to accommodate you." Because, again, people can suddenly feel very on their own and out of the loop, and what do we do now? And you just wanna kind of know that you've gotta kind of go to the next step with family members as well.
So you've said repeatedly that you do all of these things. Is this part of the program that is government supported, that each practitioner does these things in terms of telling the family the step by step, reminding the family to call the funeral home, all of these, like, people can expect that wherever they are in this country?
Absolutely, absolutely.
Great.
We have now over 2,000, provider assessors, most of whom are family docs, believe it or not, and now, a rising number of nurse practitioners who very often service rural and remote areas, and who very often are the ones servicing very specific populations of, like, indigenous peoples and that kind of thing. So, we don't have robust numbers of practitioners. I always thought every family doctor in the country would wanna look after their own people in this way, and was surprised, along the route to sort of realize that, no, they don't wanna do that. They want me to do that. So, having 2,000 doctors across Canada, is not a large number. So it's probably good that we are kind of down to about, 16, 17,000 deaths per year now, and that's kind of probably where we will in the range be, because you can be very, very busy. And in fact, there are a small group of physicians in this country who provide a, a big wonk, like 30% of all May deaths are done by a small group of doctors here.
You say that you're surprised that more GPs aren't interested in providing this for their patients. And yet so many people ask the question, how do doctors reconcile their oath to keep somebody alive with the MAiD program? So explain to me why you're surprised on one end and why people question it on the other hand.
Yeah, yeah. No, I thought, I'm a dinosaur, okay, I'm a family doctor. I sort of thought, your job as a family doctor is to look after from people from cradle to grave. And, I was a practitioner for 45 years. Of course, I look after people at their end of life. I've looked after them their whole life. Why would I not help them die? But that was mistaken on my part. I thought every family doctor would want to do that. So it shocked me that they didn't. It shocked me. And so there are 300 or so doctors across Canada who do a large percentage of MAiD procedures, whether it's Vancouver or Quebec, whatever. But the rest of us don't do that. We'll do, upwards of 10 or 20 in a year, but not 20, 30, 40.
What conversations do you think people need to have with themselves and their loved ones about end of life care?
Yeah, it's about quality. It is going to be always about what defines values, what defines quality of life issues. I mean, because we talk about that, this is all quality of life issues. This is a quality of life management. Even if you're talking palliative care, it's quality of life. But that misses very often for people their value system. And when you think that the vast majority of people who are requesting and receiving MAiD are white, are not kind of in the lowest socioeconomic class, in my population of people are very often university educated, very often have had very kind of independent, self-directed, self-driven lives. And why would we not think that their death would fall into the same categorization of values and meaning and purpose? So when you sort of start to think about why do people ask for it and what determines people's request, from my perspective, it all comes down to how did you live your life? What are your values? And when you talk about quality of life issues in terms of your ability to function, your ability to have meaningful activities every day, your ability to enjoy the things that have kind of always excited you and entranced you, whether it's opera or, the library or reading or golfing or, downhill skiing. It is about what you value in your life that is really going to determine what you value in your death.
Very, very important things to think about. 2 more questions and then I'll let you go. Promise. You talk about in the wonderful book, The Last Doctor, which I love so much, and I really highly recommend anybody seek out that book. It's framed talking about 7 different patients who are looking to access MAiD, and each case brings about a different ethical or even procedural challenge for Dr. Marmoreo, and it is instrumental in understanding just how complex this can be and also how simple it can be. I think the book does both very effectively. One of the things you talk about in this book, one of the things that has been talked about the MAiD program, and because of the core of what this podcast is about, I would be remiss if I didn't bring up the suggestion that if we had better palliative care in this country, we would not require MAiD.
I
It's
think we would always require MAID as a part of really good palliative care. One of the things that occurred around MAID, and I think this is one of the beneficiaries of the whole process of MAID provision in the country, is that it suddenly brought a spotlight on palliative care.
Mhm.
And not that we didn't have palliative care, we had unrecognized palliative care. But once you had to put MAID into the mix, then MAID actually becomes part of a palliative care package. If you're saying palliative care is about care at the end of life, boom, then MAID is part and parcel of care at the end of life as a choice. But the fact that you suddenly brought MAID into the forefront said you better really address palliative care as well. So it came out of the closet a little bit. It became what it is, which is palliative care, how to support people with symptoms, how to support people at end of life. So it is not a two against, it is a two together kind of process. And I think over time, we now know that palliative care is more accessed, is more available, like available in 80% of the situations in terms of track one people. And I've certainly had people who needed palliative care, who deserved palliative care, and who chose not to have it. But the fact is, it was there for them. We had the means and the tools and the people and the bodies to do it because it's now been more legitimized, if I can use that word.
Yeah, yeah, absolutely. I think that's a fair word to use. I think we're doing better at actually calling things what they are and having them properly defined so that there isn't confusion. And I think that you're doing the lion's share of so much of this work in terms of really allowing people to understand it. I end every single episode of this podcast with the same question.
Mm.
How can we support caregivers better?
Yeah. Well, I think in terms of the MAID process, we have actually now put things in place that came out of kind of the whole evolution of the curriculum of MAID, because caregiving support and caregiving burnout became a real big issue around sort of people walking in to provide MAID for families, and then knowing that out in the aftermath that you wanted the support to continue. So again, if you're in a hospital-based system, you've got social work, you've got care managers, you've got people kind of helping the whole family kind of get through the process and understand what is available, what isn't. If you're in the community, very often you walk out of that house and you may not hear from them again ever. So being able to provide family supports, and even in terms of doing assessments for people,
Yeah.
if am doing an assessment and what I see is the person who needs the most care is the family caregiver who is doing this 24/7. I am sort of saying you must at the clinic visit actually access the case manager and start to get more help into your home. And the fact that you can now do the home at care, you can self-refer as a family. I very often say you have to call help at home and you have to make sure that there's a nurse coming in to sort of do this assessment. you need more help, especially around Alzheimer's. You need the Alzheimer's Society. You need a companion in here. So that's my job to sort of say the help is there, accessing the help. If you haven't got, somebody sitting at the clinic bedside with you, is really up to me to sort of say, you need help at home here.
Well, I'll tell you, I'm taking on some of that load as well. I feel like this podcast is all about allowing people to understand some of the resources that are out there for them in terms of help, to actually understand what the load is when people are caregiving. And also, it's not just about that, it's also about making sure that our seniors are living the best quality of life that they can live with the people who love them most, helping them to do so.
Exactly. Yeah.
Thank you so very much. You should be so incredibly proud of you and your colleagues. You have changed the quality of end of life for this country forever.
I'm glad on that because I think we have. I truly think we have done that.
Dr. Marmoreo, thank you so much. You are a national treasure. We would not be as progressive as we are without people like you and exactly you. So thank you.
I thank you too. Been great.
Thanks so much to Dr. Jean Marmoreo for being here and pulling back the curtain on such important issues that, as I said in the intro, I know we've all thought about and probably talked about with our loved ones. This episode of The Heart of It All is brought to you by capitaldirect.ca. We love hearing from you wherever you want to reach out. All those social media platforms, you know them. Let's see, there's Instagram, TikTok, Facebook. We are there and we will always respond. We also love it when you share our episodes with your friends, your family, your colleagues, anybody who you think would benefit from this information. We do know people want to learn more about this topic, and we hope this helped those who are interested. Thanks so much to my co-producers, Jess Carroll and Carrie Hayden. I would not be able to do this without them. And you know what? We wouldn't do it at all without you listening or watching. So thank you, and please take care. This week's recommendation is one of the best filmmakers in the world right now, Pedro Almodovar's movie, The Room Next Door. It stars Julianne Moore and Tilda Swinton, and also John Turturro, in performances that are just so incredibly touching and deal with exactly what Dr. Marmoreo and I are talking about in this week's episode: the right to choose how we die.